Thank you so much, Harry. And time is upon us. We are ready for the new CoPs that go into effect on the 13th. I'm hoping that everybody is about there. I know it's a lot of stress and a lot of work in trying to get ready for the new conditions of participation. One of the big things is going to be care planning and care coordination. Again, it starts on January 13th, and it's really based around patient-centered care. And this is really a new concept in the manner that they're talking about patient-centered care. Most agencies think that we're doing patient-centered care, but we're really not very good at achieving that. A lot of times we look at, you know, what's best for the agency, what's best for the clinicians. If we're setting up a schedule, we try to set the schedule up with what is best or reduce mileage for the clinicians. But patient-centered care will change a lot of that. And so we'll talk a little bit about it. And I think conceptually, that's where a lot of us are struggling. We're really good operationally at putting in pieces of paper, even new patient rights, how we're going to work that process out. But really, patient-centered care and the idea of patient-centered care, you're going to have to get staff involvement. One of the big things I've noticed with agencies, I've had 2 agencies within the last week that have been cited on surveys, and the new conditions aren't even out, for not having specific care plans based on the patient. So I do believe we will see more of that. And while EMRs are our friends, and I don't know if we could live without them, that a lot of that has tried to make it easy for clinicians, and clinicians have forgotten how to do anything but follow a care path or follow a template, or because it's easier for documentation. So we're going to talk a little bit about what is patient-centered care first. So the medical model, or how we're operating now, versus the patient-centered model. And again, patient-centered care came about with the Affordable Care Act, as a lot of our rules of late have done. And it is across the care continuum. It's not just for home care, but hospitals are struggling with it. Skilled nursing facilities are struggling with how to implement patient-centered care. So the medical model, or how we are now, the patient's role is very passive, they're quiet, and we're basically directing them. In the patient-centered model, though, the patient's role is very active. They ask a lot of questions, and they're a partner in our treatment plan. So when we talk about care coordination, the patient is part of that treatment plan. They're part of that care coordination, and so are their patient-selected representatives. In the medical model, or a traditional model, the physician or the clinician dominates the conversation and doesn't offer options. But under the patient-centered model, the physician or the clinician collaborates with the patient, offers options, talks about pros and cons for those options. In the medical model, the care is disease-centered, and then in the patient-centered model, it is quality of life-centered. So that's a big adjustment for us. We still have to meet that payment regulation, which is driven off of care, disease-centered care. But under the patient-centered model, we have to then incorporate quality of life-centered. So what we're doing focuses on the family, the patient, and other things that goes on with that patient that affects their quality of life. In the medical model, the physician or the clinician does most of the talking, and in the patient-centered model, the physician or the patient listens more and talks less. And CMS believes that the patient-centered model, if implemented correctly, the patient will be more likely to adhere to a treatment plan as opposed to a treatment plan that we've derived for them. And that move to patient-centered care has been happening for a few years. In 2015, the Institute of Medicine defined patient-centered care as providing care that is respectful of, responsive to individual patient preferences, needs, and values, and ensuring that patient values guide all clinical decisions. There are 8 elements of patient-centered care. The first one is to respecting of the patient's preferences, values, and desires to stay informed. The second one is providing emotional support for patients' concerns, such as if they have a lot of anxiety. The third one is ensuring patients' physical comfort is managed, such as pain management. The fourth one is informing and educating patients about their conditions. The fifth one is ensuring continuity of care and transitional assistance after patients are discharged. The sixth one is coordinating and integrating care between care providers, hospitals, and/or clinics. The seventh is enabling of patients to access to care whenever care is needed. And the last one is including family and friends as caregivers and decision makers. Excuse me. Now, just like any conditions of participation, not necessarily the new ones, but any conditions of participation, one area touches several. And so if you have a deficiency in one area, just by doing one thing wrong, it may give you several different G tags. That being said, we don't really have G tags yet. The final interpretive guidelines still are not out, but CMS has directed the surveyors that they're to use their best judgment from the draft interpretive guidelines. They don't think that the final interpretive guidelines will have much variation from the draft. And I think the big thing is with the final interpretive guidelines, we will have G tags. Now, they've already said that agencies who are surveyed in the first year would